All right. Well, again, thanks for being with us. You have joined in the Systems for Action Research Program in our recurring webinar series, Research in Progress webinar series. Thanks so much for joining us today. If you're new to Systems for Action, we are a national research program funded by the Robert Wood Johnson Foundation, and we study ways of aligning and integrating medical care, public health, and social service systems, specifically in aligning those delivery and financing systems across sectors in ways that can advance the cause of health improvement and health equity and help to dismantle forms of injustice and discrimination within these systems. My name is Glen Mays. I am a professor here at the University of Colorado School of Public Health, and I have the privilege of directing the National Program Office for Systems for Action. Today, I'm actually your speaker, so you're going to have to deal with me for the full hour today. I'm going to be presenting some research from our intramural research team that's based here at the University of Colorado. Again, this is a platform. We come at you with this webinar about twice a month and feature one of the research studies that is supported through the Systems for Action program. We fund studies all around the country. Many different states, many different contexts, again, testing a variety of ways for helping to align medical, social, and public health systems. And we got our own research team based here at University of Colorado that also contributes to this body of evidence and research, and that's what I will be sharing with you today, particularly around sharing with you some findings from our ongoing study looking at geographic variation in the implementation of equity-centered public health practices. Before we get started, just a couple of housekeeping issues. One is that all of you who have joined us for this webinar today are on mute. We have a large audience today, so you're all muted, but we will have time for Q&A toward the latter part of our hour today. So if you've got a question, you can feel free to type it into the Q&A box, which you should see an icon down at the lower portion of your screen. Click on that. You can type in your question. I'll get to as many of those questions as we can during the latter part of the hour today. If I miss your question, if you register for this webinar, we've got your contact information. We can follow up with you. Apologize in advance if we don't get to all the questions today. Other thing to remember, as we always do, we record these sessions. So if you've got colleagues who are not able to be with us live today, you can check back on our website at systemsforaction.org. In a day or two, you'll see the recording of today's session, and also the slides will be posted there as well. So feel free to access that. Last thing I'll do is a blatant advertisement. I'll do it right up front, just to make sure that folks are aware. We're a national research program. One of the things that we do is fund new research studies that are testing ways of aligning medical, social, and public health systems. And we have a current call for new research proposals that was published back on January 15th. It is out there, and we want to make sure that everybody who may have an idea for a study to test an innovative way of aligning systems. We want to make sure you're aware of this funding opportunity. I'm making you aware of it right now. You can access more information about the funding opportunity, how to submit an application. Again, on our website, it is systemsforaction.org. The deadline, I can tell you, for that funding opportunity is June 4th, 2025. Don't wait till the last minute to start putting your application together and submitting it. So feel free to access more information, guidance, templates, all that kind of stuff about this funding opportunity on our website. And without further ado, I'm going to jump in and share with you some of the research that we're doing around equity-centered public health practices. Again, this is work supported by the Robert Wood Johnson Foundation through the Systems for Action Research Program. I want to send out a special kudos to our intramural research team, a great team of graduate students here at the University of Colorado that help us do this work. They're Names are shown here, folks who have contributed to the data collection and the analysis I'll be sharing with you today. And of course, the findings that I'm sharing with you are preliminary, subject to change, and these findings and conclusions represent my own work, do not necessarily represent the views of the funders at the foundation or other collaborators, past and present collaborators in this work. So just to set the stage and the motivation for this research, this research, like a lot of our studies in S4A, are grounded in trying to find solutions to health inequities that exist across populations in the U.S. One of the largest inequities that we see across racial and ethnic groups in the U.S. are inequities in life expectancy, one of our general, most basic summary measures of population health, how long we live. And we see large and persistent disparities in life expectancy across racial and ethnic groups in the U.S. And as this slide highlights, those life expectancy disparities actually grew larger during the period of the COVID-19 pandemic. All population groups, or most population groups in the U.S., saw significant reductions in life expectancy during the COVID-19 pandemic, due not just to the virus itself, but due to other social, economic, and environmental risks and circumstances that also contributed to reductions in life expectancy. But as this slide shows you, racial and ethnic minority groups were harder hit, took a larger reduction in life expectancy compared to white populations in the U.S., with Black, Hispanic, and especially American Indian, Alaska Native populations seeing the largest reductions in life expectancy over this period. While we've seen some bounce back in the post-pandemic period with regard to life expectancy patterns, we're starting to see some progress and again, gains in life expectancy over the last 1 to 2 year period. We still haven't recovered the life expectancy levels that we saw pre-pandemic. So still now, 2015, we see larger gaps in life expectancy across these racial and ethnic groups than we had pre-pandemic, and continuing to call attention to the need for ways to help all populations across the U.S. get back into a pattern of realizing gains in life expectancy, but especially closing these persistent life expectancy disparities for racial and ethnic minority populations in the U.S. The work I'm presenting to you today is going to focus on the public health sector and its role in helping to mobilize multi-sector strategies to improve health and to protect populations to prevent and protect populations from preventable diseases and injuries across the U.S. Those of you who may be less familiar with the public health sector in the U.S. and our delivery and financing systems for public health, this is a quick snapshot of what the sector looks like. We have a very decentralized, interorganizational, intergovernmental approach to organizing and financing public health activities in the U.S. Our system is essentially a federation of more than 3,000 local government agencies, about 56 state government and territorial health agencies. Of course, we have our lead federal agencies, CDC being the most prominent federal agency charged with carrying out public health functions, but some of those functions divided among other federal agencies like HRSA, EPA, U.S. Department of Agriculture, et cetera, and then lots and lots of non-governmental partners that play a role in collaborating with government to actually deliver public health interventions on a population-wide basis. Our system has a broad scope of activity and responsibility, including the long list of responsibilities you see on the left-hand side of this slide: assessing health needs and risks, investigating health threats in the population, actually implementing prevention strategies in the population, educating the public and other key stakeholders, educating and offering guidance for health professionals, for making policy recommendations and advice for our policymakers, and actually doing direct clinical service delivery in some settings to make up for gaps in the private sector healthcare delivery system. On the right-hand side, you see the resources that flow into the public health system, which are limited and highly variable. The federal government is a minority investor in the public health system in terms of spending most of the money that flows into public health agencies and systems, especially at the local level, come from local and state government sources. And we know those are generated by things like income and sales tax revenue, tightly tied to the overall size of the tax base and the economic activity in those state and local areas. And so, low resource, low income communities have less money to invest in their public health systems. And we see that in measures of disparity in public health spending, like you see on the graph on the right-hand side of this slide. So large inequities in the resources that flow into the public health system as you look across different communities across the U.S. And those inequities are in part tied to overall levels of economic activity and affluence across states and communities. We had some really helpful recommendations that were issued a couple of years ago, particularly around how the public health system can strengthen its approaches, specifically around advancing the cause of health equity and in doing a better job at preventing disease and promoting health, specifically among racial and ethnic minority populations and other populations that are disproportionately affected by rates of preventable disease and injury. These recommendations came to us through a report from the National Commission to Transform Public Health Data Systems, released back in 2021. This was a report that laid out a set of recommendations for how public health systems could do to more focused efforts in implementing public health activities through an equity lens, really paying careful attention to the population subgroups that are disproportionately affected by preventable disease and injury and targeting their health promotion and disease prevention activities to those inequities and the populations that experience those inequities. Those recommendations have now been out for about 4 years. And so we realized we had an opportunity in some data systems to study what may be happening across the US with implementing some of those recommendations around equity-centered public health practices across the US. And that's the focus of this work I'm sharing with you today. So what do we do? What are we doing with this line of research? Well, we're using data from a fairly unique data source, the National Longitudinal Survey of Public Health Systems, to examine the extent of variation in implementation of equity-centered public health practices as recommended by that National Commission. And particularly, we are looking to answer the questions shown here at the bottom of this slide. What proportion of U.S. local public health jurisdictions report implementing equity-centered public health practices? Where are those practices most and least likely to be implemented across the U.S.? What factors seem to be driving variation in the implementation of those practices? And then finally, do we see any association between implementation of equity-centered public health practices and improved health outcomes, particularly for racial and ethnic populations? That last question or aim, definitely we're treating as kind of an exploratory aim. We're looking for some preliminary evidence about patterns of association between doing these equity-centered practices and what kind of health outcomes we see at the population level. Tell you a little bit more about our data source for studying this work. We're using data from the National Longitudinal Survey of Public Health Systems, or commonly known or acronymed as NALSYS. This is a national survey of communities across the U.S. that was started more than a couple decades ago, going on about 27 years ago. Started back in 1998 was the first wave of the survey. The survey follows a nationally representative cohort of about 600 U.S. communities. These communities are defined as the jurisdictions that are served by local public health agencies across the U.S. In most cases, these communities are defined based on county boundaries, but in some cases, these jurisdictions follow other kinds of geopolitical boundaries, but mostly county boundaries. The survey has been implemented in this nationally representative sample of communities again for the first time in 1998, and then periodically the survey is re-administered to these communities over time. And over the last decade or really more like 15 years, we've been administering this survey on a regular cycle about every 2 to 3 years. In fielding the survey, we asked the local public health officials, the officials who the lead administrative officials for public health agencies in these jurisdictions, to report uh, a variety of information about public health practices that are implemented within their community, in their jurisdiction, and information about the types of organizations that help to implement these activities. We ask specifically on this instrument about a set of 20 nationally recommended public health activities that have been widely recommended by a whole variety of national and federal bodies, public health practices that are recommended for implementation in every U.S. community to advance health promotion and disease prevention objectives. So we ask about the availability or the implementation of each of those 20 activities in each of these communities. And we also ask questions about the types of organizations that help to implement these activities. These are public health activities. So in general, they need to be there's not a single organization or agency that can fully have responsibility for implementing the activity. Generally, these practices are designed to be implemented collaboratively by multiple organizations in the community. So we ask about which organizations are helping to implement each of these activities in each of the communities, in each of the time periods that we field the survey. That gives us really rich information about the network of collaborating organizations that help to implement public health activities in these communities. And we can do lots of interesting analytic work with that data to characterize the structure, the organizational structure and function of multi-sector public health networks using these data. And again, the most recent wave of data collection from this survey was completed back in 2023. We'll soon be fielding the 2025 edition of this survey later this year. This slide kind of summarizes a bit about the developmental history of this survey. Originally was started and created with funding from the federal CDC. Robert Wood Johnson Foundation has been funding and supporting this survey for the last couple of decades through the Systems for Action research program. Again, the 20 public health practices or activities that are included on the survey come from a variety of national and federal reports and recommendations about public health activities that are recommended for implementation in every U.S. community. The survey link aligns very closely with the foundational public health capabilities shown here that were articulated by the National Academy of Medicine back in their 2012 report on for the public's health. We've used these data over time for a variety of purposes, including especially to classify and compare the strength of local multi-sector public health systems around the country. This slide kind of shows you the approach that we've used of classifying the strength of public health systems into these three broad classifications of comprehensive systems that deliver a broad scope of recommended activities and that have dense collaborating networks of community partners to help to implement those activities, ranging down to at the bottom of the scale, limited public health systems that are able to support or implement only a limited scope of those recommended activities and that have a more narrow network of collaborating organizations that help to implement those activities. And we've used that classification system to show through prior research that places that have strong and comprehensive public health systems generally experience improved health outcomes, particularly as we look at the outcome trajectories, the trajectories of health and well-being in these communities over time. This slide shows you results republished from earlier research showing that communities with comprehensive public health systems have significantly lower mortality from preventable conditions like heart disease, diabetes, cancer, even influenza. Again, using strong quasi-experimental methods to estimate the potential causal effect of strong public health systems on these outcomes. We've also, through prior research, shown that Comprehensive public health systems help their communities lower the growth in medical spending over time by preventing disease so that those diseases don't advance and need more expensive medical treatments to intervene on them. So places with strong public health systems generally have lower rates of growth in medical spending over time, again, based on work we conducted and published previously. This slide shows you the specific set of 20 public health practices or activities that are measured on the survey. They fall into the three broad domains of core public health functions identified by the National Academy of Medicine. Those functions being public health assessment, public health policy and planning, and public health assurance or implementation activities. Again, we have measures of in the survey for each of these 20 activities, and then for each of these activities, we have measures of the array of organizations that help to implement each of these activities in each community. This slide shows you a little bit more about the structure and content of the survey. I'm going to call your attention to the last bullet of this slide because it shows you a new set of questions that were added to the survey beginning in 2018. And these are the equity questions that were added specifically to the survey to help us track the extent to which public health agencies and their collaborators were implementing public health practices in an equity-centered manner, consistent with the recommendations of the National Commission to Transform Public Health Systems. And this slide shows you specifically the sub-question that we added to each of the 20 public health practice questions on the survey. So beginning in 2018, we asked for each activity, what proportion of the effort devoted to this practice focuses on addressing health inequities and health disparities experienced by racial, ethnic minority groups and other marginalized population groups in your jurisdiction? We use a standard Likert scale to elicit that information from the survey respondents. That's really what gives us a measure of the extent to which each public health practice is being implemented in an equity-centered or equity-focused manner that's taking into account the needs and the issues of racial, ethnic minority populations and other marginalized population groups. So we asked that sub-question for each of the 20 public health practices that are included on the survey. That gives us our measure of the extent to which communities are using equity-centered or implementing equity-centered public health practices consistent with the recommendations of the National Commission. Again, this set of sub-questions was added to the survey just in 2018, and then we retained these questions in the most recent wave of the survey filled in 2023. So we have at least a couple of years now where we can look at both geographic variation and longitudinal change in implementation of these equity-focused public health practices. This slide just gives you a little bit more detail about the types of organizations that we measure on the survey as being potential contributors to implementing public health activities in communities. There's a large list of about 34 specific types of organizations and settings that are asked about on the survey. And again, for each of the 20 activities, we ask, which of these types of organizations helped to implement that activity in your jurisdiction? So this gives us that rich kind of network data on the density of networks of collaborating organizations that help to implement these activities in each of the communities. So that's all the data we capture through the National Longitudinal Survey of Public Health Systems. For studies like this one, and many studies that we use these data for, we link our survey data with lots of other secondary data sources to help us, again, study causes and consequences of variation in implementing public health practices and help us study the outcomes that are attributable to implementing public health activities, including equity-centered public health activities as we're now measuring in the survey. This slide shows you some of the secondary data sources that we link with our survey, generally using local jurisdiction identifiers, county identifiers essentially, or their or similar geographic identifiers. For the analysis I'm sharing with you today, where we primarily our outcomes for this analysis, measures of mortality, are coming from the CDC's compressed mortality file, the cause-specific death rates by year and by county that we're able to link with our longitudinal survey data. This slide just shows you a little bit more about our population and sample. Again, we're studying communities. Our sample are local communities as defined by the local jurisdiction, the jurisdiction of the local public health agency in each of these communities. For the most part, as I mentioned, these are county-based jurisdictions. 82% of our sample, these are county-based jurisdictions. There are some other types of public health jurisdictions included in our sample, including city or town-based jurisdictions that are generally smaller areas within counties, but sometimes are cities that cut across multiple counties. Then we also have some multi-county or regional public health jurisdictions in the sample as well. Our overall research design and analytic methods, I mentioned we link our survey data with the CDC mortality data. We focus on the waves of the survey fielded in 2018 through 2023. For our analysis, we use a two-stage modeling strategy that uses generalized linear models along with an instrumental variables estimator to estimate whether places that report high levels of implementing equity-centered public health practices, to examine that association with county-level preventable mortality patterns, both overall and preventable mortality as measured across specific racial and ethnic minority groups. And this two-stage GLM estimation strategy with the instrumental variables modeling allows us to essentially estimate the impact of implementing equity-centered practices while controlling for both observable potential confounders, but also controlling for potentially unmeasured confounders or unmeasured differences across communities that implement equity-centered practices and versus those communities that don't implement these practices or that implement lower levels of equity-centered public health practices. So it's a two-stage modeling strategy. We first estimate the likelihood that a community falls into our classification of implementing high levels of equity-centered public health practices, and we look at the factors that predict high levels of implementing equity-centered practices in that first stage equation. And then we use results from that first stage equation to estimate the impact of implementing high levels of equity-centered practices on rates of preventable mortality, both overall and for specific racial and ethnic groups. Again, controlling for a variety of observable differences across communities, and also using our instrumental variable strategy to control for potentially unmeasured differences or unmeasured confounders between communities. You can see at the bottom of this slide, the kinds of characteristics that are measured and controlled for in this modeling strategy, including demographic and socioeconomic characteristics of each community, characteristics of the healthcare resources available in each community, physician and hospital resources, health insurance coverage, as well as state and year fixed effects. All right, so that's the setup. That's a bit about the data source. That's a bit about our research design analytic strategy. Let me share with you some preliminary results and what we're finding in this study. This first slide just shows you some descriptive statistics for an overall measure of the extent to which these 20 nationally recommended public health activities or practices are implemented in communities across the U.S. This is using data from the most recent wave of the survey filled in 2023. You can see this is a classic histogram showing, fairly wide variation in the extent to which communities report implementing these nationally recommended activities. There are about eight on the right-hand side of this distribution. You can see there are about 8%, about 7% of U.S. communities that report implementing all 20 of these public health activities in the recent wave of the survey. On the left-hand side of the distribution, you can see that there are, communities that report implementing less than a quarter of these nationally recommended public health activities. So we still see a lot of geographic variation across the U.S. in the extent to which these public health practices are implemented. If we look kind of at the central tendency, what is the average community report in terms of implementing these recommended activities? On average, the average U.S. community reports implementing about 65% of these 20 recommended public health activities. As I mentioned, we can use the network data that's captured through the survey to actually characterize and in this slide, as this slide shows, visualize the structure of the collaborative networks that exist in each community to help implement these public health activities. This is a classic network diagram. In this case, it's showing you what the average network looks like, the types of organizations that collaborate in implementing public health activities in the average U.S. jurisdiction in 2023. The size of the squares show you types of organizations or sectors that are playing larger roles in implementing a larger proportion of these 20 public health activities. And you can see on average, it's local public health agencies, hospitals, nonprofits, schools, educational organizations are some of the more prominent organizations that play a role in implementing these activities. The thickness of the line here shows you for any pair of organizations how frequently those organizations, that pair of organizations, work together in implementing the 20 public health activities measured on our survey. So thicker lines show you more collaborative activities between dyads or pairs of organizations in these networks. And so again, we're looking at the average U.S. community in this diagram. We see thick lines connecting, for example, public health agencies, nonprofits, community health centers have some thick lines connecting them to collaborators here. Also, again, hospitals over on the left-hand side, some thick lines connecting hospitals with other units of local government, with physicians, with educational organizations and schools. So it provides a way of summarizing and even visualizing the collaborative structure of public health delivery systems in these communities. So what do results look like in terms of specifically implementation of these equity-centered public health practices? This table, I'm summarizing data again from the most recent wave of the survey, and we're looking at each of these 20 public health practices measured on the survey. The first column shows you the proportion of communities that report implementing that activity at all, the proportion of U.S. communities that implement that activity in this most recent wave of the survey, 2023. The second column shows you the measure of equity centeredness. So how, to what extent is that practice implemented in an equity centered manner? Again, using that Likert scale I showed you earlier, that 0 to 100% scale that we use for measuring equity centeredness. And you can see that for each of the 20 activities shown on the slide. And then down at the bottom, we construct a composite measure of implementation and a composite measure of equity centeredness in implementation by summarizing these measures or summing them up across all 20 public health practices. So what does this data show us about the extent of equity centeredness across the U.S. in implementing nationally recommended public health practices across the U.S.? Well, first thing I see in looking in that second column, we see relatively low rates of reported equity centeredness in implementing public health activities. You can see for most of these activities, the equity centeredness score, and this is averaging across all communities in the U.S. You can see that score generally falls on the lower end of the 0 to 100% scale. Again, if all U.S. communities reported implementing high levels of equity centeredness on these activities, we would see numbers closer to 100%. Instead, as you scan down the table here, you're seeing numbers in the high numbers are 33%, for conducting a community health needs assessment, or 34% for activity number 7, implementing a communication network in the community. About 35% for activity number 9, prioritizing community health needs, doing that in an equity-centered manner. So overall, we see relatively low levels of self-reported equity-centeredness in terms of how each of these public health activities are being implemented in the community. Um, Even there, we see quite a bit of variation across the individual practices in equity centeredness. Again, the highest equity centeredness measures we see are, only up in the 34-35% range. At the low end of the spectrum, we see some activities, again, as low as 12%. Activity number 14 being the equity centeredness score on that measure being only about 12%. And you can see some of the other more lower activities that score lower on that equity-centered scale being activity number 12, for example, allocating resources consistent with the Community Health Action Plan. So having an equity-centered approach to resource allocation scores relatively low on that equity-centeredness scale. If we look down at the bottom, see if I can move this bar so you can see that last row. That last row in red shows you our kind of composite measure when we average these scores across all 20 public health activities. You can see, again, the average implementation score for all 20 activities is about 62%. So the average U.S. community implements only about 62% of these 20 public health activities in 2023. The average score for equity centeredness across all 20 activities is only about 26% on that 0 to 100% scale. So the average U.S. community is still down at that kind of at the upper portion of the bottom 25% or so of that equity centeredness scale. So that tells us, obviously, there's a lot of room for improvement in many public health jurisdictions around the country in implementing these activities consistent with an equity-centered focus. All right, let me move along. So we use that composite measure of equity centeredness that I showed you at the bottom of that last table, that composite measure, averaging the equity centeredness scale across all 20 public health activities. We use that to construct an equity centered composite measure and actually a dichotomous measure of equity centeredness. So we use that composite measure to basically construct an indicator variable telling us which communities had relatively high levels of equity centeredness in how they implemented public health activities. And this slide just shows you how we define that threshold of high equity centeredness. We just looked at the frequency distribution of that equity centered composite measure and looked at where we see kind of a clear breakpoint in the distribution of that equity centered composite measure. And we see that breakpoint at about 0.4 on the 0 to 100% scale. And that's the threshold we use for defining communities that have high levels of equity centeredness in implementing public health activities. Those communities that scored at least a 0.4 on the 0 to 100%, or at least a 40% on the 0 to 100% scale for the equity centeredness composite measure. That is our functional definition of a community that exhibits relatively high levels of equity centeredness in implementing public health activities. So that becomes then just a dichotomous measure telling us which communities meet our definition of showing relatively high equity centeredness in implementing their public health activities. And that's the indicator variable that we then use for our subsequent analyses that I'll share with you now. First results I'll share with you are results from the first stage of our two-stage model of studying equity centeredness and its relationship to health outcomes. In that first stage equation I showed you early, we estimate factors that are associated with communities meeting our definition of showing high equity centeredness in the implementation of of public health activities. And in that model, there were four covariates that were stood out as being statistically significant and showing relatively strong levels of association with a community having high equity centeredness in their public health activities. And it's these four covariates that I'm showing you here. First of all, communities that had an independent policymaking local board of health, a local board of health with the authority to implement policies in the community. Those communities were significantly more likely to meet our definition of having high equity centeredness in their public health activities. Those communities with policymaking boards of health were about 7.2% more likely than communities without these boards in more likely to be a high equity centered jurisdiction in terms of how they carry out their activities. Secondly, communities with larger racial and ethnic minority populations, not surprisingly, were more likely to meet our definition of a high equity centeredness in the implementation of these activities. For each 10% increase in the share of the population from a racial and ethnic minority group, each 10% increase was associated with about a 9% higher likelihood of being a high equity centered public health jurisdiction. Third covariate that popped out as being a significant predictor of equity centeredness was the density of the network of collaborating organizations that are engaged in implementing the public health activities measured on our survey. Again, not surprising to us based on our prior research. Communities that had larger networks of collaborating organizations that helped to implement these activities were more likely to meet our definition of being a high equity centered public health jurisdiction. The coefficient estimate there showed us that for each 10% increase in the density of the collaborating network, each 10% increase in that density was associated with about a 12% increase in the likelihood of being a high equity centered public health jurisdiction. The one covariate that was inversely or negatively associated with being a high equity centered public health system was actually designation as a rural jurisdiction. Rural areas were about 12% less likely to be classified as a high equity centered public health jurisdiction using our composite measure, showing you that there is a pretty large and substantial source of geographic variation in implementing these equity centered public health practices, again, particularly disadvantaging rural areas. So final result I'll share with you, then we'll get to some implications and some Q&A. In this final slide, I show you results from the second stage of our two-stage GLM instrumental variable analysis. That second stage of the model estimates the association between implementing public health activities in a high equity centered manner and how that is related to preventable mortality rates overall and specifically for minority populations. This slide shows you that coefficient estimate of the association between being a high equity centered public health jurisdiction and rates of preventable mortality for all races shown in that first column, and then the association with preventable mortality specifically for Black or African American populations in the second column, and for Hispanic and Latino populations in the third column. A couple of quick takeaways here. First of all, you see for all three population groups, we see negative associations estimated here. So communities that have high levels of equity centeredness in their public health practices generally show significantly lower rates of preventable mortality. Significantly lower rates, because we're also showing you the 95% confidence interval in the black vertical bar there. So communities with high equity centeredness in public health practices have about 5% lower rates of preventable mortality across the entire population, looking at all races. But we see even larger inverse associations with preventable mortality for minority populations, specifically the Black and Hispanic populations. For Black populations, again, communities that implement high levels of equity centeredness in their practices see about an 11% lower rate of preventable mortality for the Black population compared to communities that have lower levels of equity centeredness in their practices. Similarly, for Hispanic and low and Latino populations, communities with high equity centeredness in their public health practices see about a 7% lower rate of preventable mortality, specifically for Hispanic populations. Um, so this shows us that there are potentially large health benefits that we can, in terms of preventable mortality, that we can attribute to incorporating higher levels of equity centeredness in implementing public health practices. And importantly, we see this association across the entire population for all races. Again, about a 5% reduction, but we see an even larger benefit in terms of reduced mortality for racial, ethnic, and minority populations that we examine here. And bottom of the slide shows you specific details on how we construct this preventable mortality rate. We generally use the approach pretty commonly used in this body of research about preventable mortality. Okay, so a few conclusions and implications. Number one, we see relatively low rates of implementation of equity-centered public health practices as we look across the entire population of U.S. communities. Many communities still reporting, and these are self-reporting, relatively low levels of implementing public health practices in an equity-centered manner as of 2023. So there's lots of room for improvement across the country. Places that seem to do a better job of implementing equity-centered practices appear to have stronger multi-sector collaborative networks that they can marshal to help implement those practices. So implementation of these practices appears to require or at least depend upon, strongly upon, having strong collaborators in the community that you can engage in helping to implement these practices. And importantly, those collaborative networks may be more limited in rural areas. We saw that in the results in other types of low resource areas. On a positive note, we see evidence of potentially strong benefit for places that can transition to implementing more of their public health practices in a strong equity-centered manner. We see evidence of lower preventable mortality across the board in places that have high levels of equity-centered practice implementation, and even lower levels, more benefit, more prevention benefit, specifically in mortality for racial and ethnic minority populations. So this tells us that there may be some real advantages to helping communities understand how to implement their practices in more of an equity-centered manner, and specifically our funding and our training and technical assistance models that are geared to help communities implement evidence-based public health strategies. We need to place more emphasis on how to support and even incentivize implementing those practices in an equity-centered manner. That includes building equity-centered practices into accreditation standards, into the kinds of grants that we give out to public health agencies and systems to support their infrastructure and data systems and practices, and maybe even incorporating incentivizing equity-centered practices into the payment models that we use for public health agencies and for their healthcare and community collaborators as well. Of course, we are in an environment now where there, at least in some corners of our federal government, there are efforts underway to de-emphasize, discourage, and even defund research and practice and training and education and technical assistance related to health equity. And so one clear implication from this preliminary research I'm sharing with you today is that these federal efforts that are de-emphasizing and discouraging a focus on health equity and public health practice, clearly they may have adverse real world adverse health consequences for both for the entire population, but especially for racial and ethnic minority populations. Again, based on the strength of the association that we see between these kinds of practices and the mortality benefit that we see for communities. So that's really important. There may be important adverse health consequences that result from the federal effort to de-emphasize and defund some of this work around health equity. What can we do about it as communities, as leaders in public health and healthcare and social service systems? Number one, really important for us now to distinguish the health equity work, that the kinds of health equity work that we're talking about today, and they're measured in the survey, from the more imprecisely defined kinds of DEI work that are targeted by some of the recent federal executive orders. That's really important to distinguish health equity research and health equity practice from some of the more narrowly defined DEI work that may be the target of federal executive orders. So we need to think about the language, how we define, how we describe health equity work to help our federal colleagues really understand how this work is distinguished from other activities that may be the subject of federal defunding. Secondly, of course, we need to look at alternative and broader funding sources to support health equity work more generally in communities. So I know that we are all doing this now in response to the federal orders that we're seeing taking shape now. So thinking carefully about how we can leverage non-federal funding from state and local governments, which are, again, as I mentioned, even tend to be even more important sources of funding for public health agencies. How can we leverage philanthropic non-governmental support agencies that have partners that deliver direct clinical services and medical services? How can we use clinical revenue in ways to support health equity in equitable public health practices? And of course, continuing to leverage our non-governmental partnerships, and especially non-federal partnerships who may have more degrees of freedom in supporting their health equity work. Limitations here. Our data source relies on the perceptions and self-reports of local public health officials. You know, our measures of equity centeredness that described here are added relatively recently to our survey, so we are able to measure them only over about a 5-year time frame currently. That'll get longer as we continue to field the survey. And of course, we're looking at these issues during the COVID and post-COVID periods, and so there may be COVID-related disruptions that are also helping to explain some of the findings that we see here. So with that, I'm going to stop my share and see if we can get to some questions that have been submitted. And I see we've got some questions submitted in the box. Thank you for that. First question. Would you mind sharing examples of how the data you've collected has influenced public policy? Well, this is preliminary research, not yet published. I work on equity-centered public health practices. So I doubt that these findings I'm sharing with you today, this is work in progress. I doubt it has influenced public policy to date. If it has, I'm not aware of it. We've presented some similar preliminary work at some recent national meetings at APHA and Academy Health. So it is out there. But we're still in the phase of disseminating and implementing this work. I can certainly tell you there are lots of examples of how other findings from the National Longitudinal Survey have definitely influenced policy related to strengthening public health systems and strengthening the multi-sector networks that support evidence-based public health policy, including many states that have used this work. Earlier versions of this work was actually used at the federal level to help advocate for the creation of the Federal Public Health and Prevention Trust Fund that was passed as part of the Affordable Care Act back in 2010. So there are lots of examples of how these data more generally have been used at federal and state and local levels for policy change. The equity-centered measures, again, are new. Our findings are brand new. So we're in a forward-looking position in terms of helping policy stakeholders make use of these data. Question number two. Question about that table I showed you that showed you the summary data on implementation measures and equity-centered measures, how those measures were constructed. What essentially you're asking what the denominator of those 0 to 100% measures are. The denominator there the denominator for all those measures was the full sample of responding public health jurisdictions or communities. That denominator was not limited to only the jurisdictions that reported implementing the activity. Those are 0 to 100% prevalence estimators using the full population of responding jurisdictions as the jurisdiction. So you can interpret them as the percent of U.S. communities that implement the activities and the percent of these activities that are implemented in an equity-centered manner across that full population of responding jurisdictions. Hopefully that clarifies your question, and very good question indeed. Let's see. Next question. I think, Kara, hopefully I answered your next question about your example, that denominator being the full population of responding public health jurisdictions, not just the jurisdictions that report implementing the activity. Of course, some kinds of analyses, we do subset the data based on, implementers versus non-implementers for this kind of broad estimate of looking at prevalence and looking at association with health outcomes. We use the more broad definition of prevalence using all, the 100% of responding jurisdictions. Question about differences across between men and women in health outcomes. It's a very good question, and there certainly are differences across gender and sex in mortality data. And I think this question is asking specifically about COVID-related mortality. Our analysis, first of all, we did not look specifically at COVID mortality. We looked at broad measures of preventable mortality. With future work, we could certainly, in related work, we have looked specifically at COVID-related mortality during this period. Didn't share with you those results today. There are certainly important differences across men and women in these mortality measures. We have, as sensitivity analyses, run our analyses separately for men versus women. We basically see the same basic pattern that I showed you today of again overall lower levels of mortality in places that implement high levels of equity centeredness and even larger reductions in mortality for racial and ethnic groups. We see the same patterns when we stratify based on gender. Thank you for the helpful comments. And we'll say, certainly if you want to learn more about this line of research, feel free to contact us via email. You want to learn more about our analysis survey. We do make that data available publicly for researchers across the country to use in their own studies of multi-sector collaboration in the implementation of public health practices. So feel free to reach out to us if you're interested in learning more about the data or accessing the data. And with that, we're at the bottom of the hour. So I want to thank everybody for joining us today. Really appreciate your feedback. Keep this on your calendar. We come to you about twice a month with these research in progress webinars. We'd love for you to join us for your future editions. And if you've got an idea for your own study of how to align health and social systems to advance health equity, please take a look at our current call for proposals, the current funding opportunity you can find on our website at systemsforaction.org. For now, so long. Thanks so much for joining us and enjoy the rest of your day.